Yeah, hello and welcome to Wimpole Street Dental Clinic. My name is Christian Mill, and in the following small presentation we would like to show you one of our cases of the month here made in our clinic. So thank you very much for watching and we hope you enjoy the video.
Yeah, welcome back to Case of the Month in October 2017. Case done by Master Dental Technician Mirai Pongratz and myself. And in this case, I would like to present you an implant which is not that easily to place and not that easily to restore, as we have inflammation. Here's this initial situation: a tooth 25 years in position with an inflammation distal of the tooth and an apical infection. We always do the same: take pictures of the situation, analyze the situation, take an impression to produce a model. So that we're able to produce a temporary directly after the surgery. Then, with local anesthesia, produce, in this case, a full flap to have a complete look onto the inflammation, be able to really remove it completely. Then we always split the tooth in half in mesiodistal direction. Remove the tooth very careful not to destroy any of the buccal or surrounding bone. And here we can see the extent of the inflammation with the buccal fenestration, and of course then we have to really properly clean it. And here the situation is clean, that we can prepare for the implant. This is a tooth, insufficient crown, vertically fractured tooth, metal post exposed to the bone. And of course that results in inflammation. Then preparation for the implant, in this case very easy because we have perfect site. And then placement of the implant. I always rather in the front choose a diameter of the implant which is a little bit smaller, so to make sure that we have no problem with the neighboring tooth or teeth. In this case we can be fairly sure that the aesthetic result will not be perfect, but okay, as the neighboring teeth still hold the bone. We just filled the missing bone with bone of bovine origin, covered it with membrane, and are ready now to produce the temporary, which takes approximately about 1 to 1.5 hours in the laboratory, and this time the patient rests in our practice. The implant position is transferred to the model. The implant analog is fixed with pattern resin in this case, and a PEEK abutment is placed onto the implant analog, and this splint is used to shorten the temporary abutment, and then we just use temporary implant or temporary crown material or temporary material to produce a temporary. This is the final temporary before glazing. Of course, we will do everything not to cement the temporary in order to avoid any cement rests, and screw retain it on the placed implant. Important is that the implant has roughly torque of 35 Newton centimeters, the minimum. Then place the temporary into the situation, temporary filling on tooth 1, 2 as well, and seal it with sterile Teflon bands and tetric flow filling buccally. This is the X-ray directly after the implantation. You can see we're safe when it comes to the vertical tissue situation, but distal the papilla is gone because of inflammation. And here we can see then 3 months later the final restoration, and the abutment is placed in position, and we'll in this case cement the crown, as it otherwise the exit of the crown, the screw channel, would have maybe impeded nice aesthetics because of the incisal way it would break through the incisal edge. And then the cemented crown and the picture directly after placement, and in this case half year later in the recall session, and then 1 year later, and we can see that we have lost some of the tissue height buccally and distally where the inflammation has been, but overall a stable situation, and patient is happy with that. So thank you very much for watching, and see you again soon.